Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of pharmacogenomics. Dr. Travis Brown, you've warned me I've got some tough quotes to read out during this. Why? Is it just because it's a complex area of medicine?
I think we're mixing two areas that are completely baffling from a language perspective. You get genetics and genomics, and then you get medications and generic medications, and you then jam them together, and it's an impossible mouthful of letters that I struggle with myself, so let alone yourself. So we're putting you into the torture chamber.
Magnificent.
So, but this is about pharmacogenetics, pharmacogenomics. This is about the interplay between our genes and the medications that we take. And it's actually a really new area. This area is only about 70 to 80 years old, ever. And so we look at the amazing thing about medications, when you think about it a little bit longer than, if you're looking at a packet of medication, you're looking at Panadol, or you're looking at aspirin, or you're looking at whatever. Remember, you sort of got pediatric doses that you look at and go, if we got we need to do this much. As soon as you get to the magical age of adult, they're all the same. And that's really strange. I remember hearing a hematologist talk, and he was talking about the medication doses they were using for the new anticoagulants. And they're saying, well, this is so strange because, he gets someone who's a 50 kilogram, old lady who's 70 years old will come in, and he'll prescribe it the same amount as the, 150 kilogram, 50-year-old that comes in. And he's like, we know it's not quite right. We're not taking into account the, size, weight, age, of these patients, and yet we're prescribing the same dose. And this is also now just adding in an extra element of that. What is someone's genes sitting across from us? How does that play? And
also how they metabolize things.
Well, and that's right. And this is the process of us understanding more of our medications that we're prescribing to patients. And that's what the reason is because we don't have guidelines, for, someone who's 100 kilograms versus someone who's 40 kilograms, and they might be, the same, whatever. And so this is now coming into the area of we can actually take into consideration someone's genes and their genetics about how they're going to metabolize a drug we're going to prescribe to them. And this became apparent in the 1950s with 3 drugs. Now, we've actually talked about this topic. This was with Professor Graham Suthers, and this was our final episode on This Pathological Life. And so that's a few years ago. And so the research has come out more. There's been guidelines, which we'll discuss today. But there was 3 drugs in the 1950s that this came to the forefront. One was isoniazid, and Professor Graham Suthers mentioned that. We have primaquine, which is a malarial drug that was coming into the forefront, and this was because of World War II. And this was also succinylcholine, and this was an anesthetic drug in the 1950s. And these, let's look back at World War II, and this was when did primaquine become more prevalent? And this is because the United States soldiers, what was happening is because of World War II, they then moved around and were in areas that needed anti-malarial medication. And the problem was approximately 10% of African American soldiers would have developed this acute hemolytic crisis. So the red blood cells were actually bursting as a result of these medications that they were given. And so the challenge was that very few Caucasian soldiers actually had the same adverse reaction. And so there was this genetic predisposition to this condition be given the drug. And what they ended up finding out was a condition called G6PD deficiency. And so African American genetics was such that these people had deficiencies in the area. Their red blood cells were actually susceptible to what we call oxidative stress. And then with this medication, these cells would burst. And if they eat things like fava beans, then their red blood cells could actually burst as well. And so this was a genetic condition that predisposed you, if you took the medication, that you could get into this hemolytic crisis. And so that was sort of a hint that your genes could play some role in this medication. And the other one was succinylcholine, which was a drug used in anesthetics, or is used in anesthetics. And this is what they call as a muscle relaxant, but it paralyzes your muscles so that you don't move during surgery. The problem is there's some people a small percentage of people who have something called pseudocholinesterase deficiency, which is an autosomal recessive condition that if I give you the medication, that drug acts much longer on you and it doesn't wear off as quickly. And so these patients then have to be anesthetized for a much longer time before they come out to it. Now, the key to this was noted by who we consider the father of pharmacogenomics. His name is Arno Motulsky, and he wrote a landmark paper in 1957. He wrote a paper that was called Drug Reactions, Enzymes and Biochemical Genetics. And in the premise, he wrote this:
Hereditary gene-controlled enzymatic factors determine why, with identical exposure, certain individuals become sick, whereas others are not affected.
That's a very simple, very easy to understand explanation. Now, he is
so do we stop there?
Well, he's a remarkable person. It's actually worth delving into his life because he lived at a time which was very dangerous. It was actually discussed and he detailed in a journal article which was called The Great Adventure of the American Human Geneticist. And now it's worth delving into because he was born in 1923. Now, he and his family are Jewish, and he was born on the Baltic coast of northern Germany. And, of course, in 1933, the German Nazi Party rose to power in Germany. And this was at a time when they got to power, the Jews were immediately banned from working in the civil service. Next year, Jews were banned from being in the military. They were banned from marrying Aryans, so blonde-haired,
blue eyes.
There we
yes.
go. And they were also stripped of German citizenship. And in 1936, Jews were banned from most professions. And this is just an amazing time in history. It's just an unbelievable time in history, to be honest. But in November 1938 is the night what they call the Kristallnacht. And this was called the Night of the Broken Glass. And this is when tens of thousands of Jews were pushed into internment camps. All Jewish children were expelled from schools, and Arno at this time was 15 years old. He had an interest in psychology and psychiatry at the time. Now, he had his mother, his father, a brother and a sister that he was with. At this time, he applied to Palestine into a youth program, but he had a heart murmur that they detected, and so he was excluded from going out into Palestine and continue his education. Turned out to be benign, but it didn't matter at the time. It was excluded. And so by 1939, Arno and his family, they knew they had to leave Germany. It was too dangerous. And Arno's father had a brother in Chicago, and they planned to go there, but they needed visas. And so they applied for visas, and during this time, his father was able to get to Cuba on an immigration visa. And so what they planned is his father will go over to Cuba, the visas will come across, and then they'll go and meet in Chicago. But unfortunately, things got far worse in Germany, and they thought this is the best time. They'll go over and meet up with their father in Cuba. They got immigration visas, and they'd meet up with him. By May 1939, they were able to get on the ship called the St. Louis, and this had almost 1,000 Jewish refugees on it. By the time it got to Cuba, though, Cuba then said the visas were invalid, refused them entry to Cuba. The captain was sympathetic to the plight. It was a German ship, sympathetic to the plight for the people on the ship. But unfortunately, no one in the Caribbean accepted them. They tried to go to the US. The US refused it because they were worried about angering their own sort of diplomatic relationships at that time. And the unfortunate thing was the ship had to sail back to Europe at the time.
I was 16, so still a little naive, but many of the passengers had been interned previously and knew what awaited us on our return. Some attempted suicide by jumping overboard. Telegrams were sent all over the world asking that we be allowed to disembark any place other than Germany. Miraculously, a few days before we would have arrived back in Germany, 4 other countries, England, France, Holland and Belgium, each agreed to take 1/4 of the passengers. By luck of the draw, my mother and brother and sister and I were assigned to Belgium. So in June 1939, I started high school in Brussels.
11 months later, on the 1st of May, Arno's father received the US visa and was able to move to Chicago.
On the same day, our US visas came through as well. But by May the 10th, we hadn't yet gotten out of Belgium and the Germans invaded. Leaving was impossible. Since I was now 17, I was arrested by the Belgians as an enemy alien, ironically as a German, and sent to an internment camp in France. As the Germans invaded France, we prisoners were moved further and further south until we ultimately were interned in a camp in the Pyrenees in the Vichy-controlled France. The Vichy French, who collaborated with the Germans, sent the ethnic Germans back to Germany and kept the Jews interned. The internment camps had no food or sanitation. Many prisoners died, most from typhoid or starvation.
They were able to survive, surprisingly, and then 10 months later, the Jewish people who actually had US visas were moved to other camps. Now, the problem was Arno's visa had expired, and so he pleaded for them to be renewed, which it was granted. And then they were still in the camps and clearly still had some ability to be able to move. It was under control of the Vichy French. But in June of 1941, he ended up leaving his mother, sister and brother, and he travelled across France into Spain and through to Portugal and was able to sail to America. And in August 1941, he was reunited with his father in Chicago. Now, unbeknownst to him at the time, he didn't know what happened to his mother, sister and brother. They were fortunate enough to have friends in Belgium who then found them a place in Switzerland, and they were able to survive in neutral Switzerland and were able to meet up 5 years later with the family. But Arno was 18 years old and he hadn't finished high school.
Fortunately, there was an arrangement by which you could take examinations on material you knew. I'd not had any formal school since the months in Brussels, but in the internment camps there were informal classes, since among the internees were many professors and teachers. We didn't have books, but we had our brains, so I learned quite a lot, and with the special exam system in Chicago, received my high school certificate.
Now, Arno's education took off. He would work during the week, but he would attend the local college, the YMCA, where he'd go into evenings on Saturday afternoons, where he learnt biology, chemistry, trigonometry. He ended up applying and was accepted to medical school at the University of Illinois. He ended up also, after all this, applying to the Army and was accepted into the Army. He ended up getting into a rapid physician training program, and he ended up doing internal medicine. He did a fellowship in hematology. He was fascinated by genetics, and he researched sickle cell anemia, the hemolytic anemias, and he realized, again, as we sort of touched on at the start, that genetics could determine morphology of red blood cells, what they look like, their lifespan, their red blood cell life. And so he became actually involved in research and teaching in universities. But genetics was very much at its infancy.
In the early 1950s, medical genetics was not yet taught to medical students. I was hired to teach internal medicine and specialised courses in haematology. So at UW, I used some of my haematology lectures to teach bootleg medical genetics. I made up a syllabus based on little vignettes, case descriptions for which genetics could solve the case. Word got around. After a couple of years, the chair of medicine suggested I start a division of medical genetics.
And so Arno realised that what he needed to do to learn genetics was to meet geneticists and to go to conferences. He realised that genetics was not an isolated discipline. This needed biochemistry, statistics, molecular biology.
I became interested in what we now call pharmacogenetics, that is, differential reaction to drugs among people based on their genotypes. At the Copenhagen meeting, a paper was presented on pseudocholinesterase deficiency in prolonged apnea. During surgery, the drug suxamethonium relaxes the muscles. In almost everyone, suxamethonium is destroyed rapidly by the enzyme pseudocholinesterase, and its use is benign. But in people with an abnormal, mutant pseudocholinesterase, suxamethonium is not broken down, and patients require artificial respiration. The condition was genetic. I was intrigued with the interaction of enzymes, genetics, drug reactions, and disease, and compiled a review of the then-known examples.
The projects that Arno would go to work on included genetics, pharmacogenetics, lipid disorders, coronary artery disease, familial hypercholesterolemia, colour vision, and it's just a remarkable life. The impact created essentially this division that we call pharmacogenomics, pharmacogenetics, and we're now starting to feel the impacts of that. And this is, again, 70 to 80 years old. And so Arno Matulski has been a pioneer in this area. And all of this, some of it, what he believes is his most valuable contributions.
I believe that my most important contribution to medical genetics has been mentoring hundreds of fellows and students over the past 50 years, and I was delighted when my way of mentoring became a model for the field. Part of mentoring, including reaching young scientists I don't know personally, has been writing textbooks that present our field in all its complexity and elegance.
And so this is where we find ourselves today. We are learning about how genes and drugs interact. We learn more about this. And this is where I think in this act, we leave Arno with the final word.
Throughout my career, have very much enjoyed the practice of medicine. Until I was 70 years old, I was an attending physician in general internal medicine. The human contact, to be able to help people, is enormously rewarding. And I always learned something. I was stimulated to ask new questions by seeing things I hadn't previously thought about. And with respect to medical genetics in particular, I know of no other field in science and medicine that is as fascinating. Medical genetics is closer to science than most specialities in medicine. It reveals exciting new biological phenomena. It has social implications and historical implications and ethical implications. I cannot imagine having done anything more exciting for the past 70 years. Professor Luke Hessen is a clinical scientist with more than 20 years' experience in pathology and research. He's the manager of the genetics department at Douglass Hanly Moir Pathology and provides scientific supervision of genetic testing, including pharmacogenomics. He's also co-chair of the RCPA Pharmacogenetic Advisory Group, which recently provided guidance for prescribers, pharmacologists and pathologists regarding clinical indications for pharmacogenomics testing in Australia. Luke's our guest on This Medical Life. Luke, welcome.
Thank you very much. Thank you for having me.
Let's start by defining some terms. What is pharmacogenomics?
So pharmacogenomics is the study of how genetic variation can affect our response to medications. And it's part of the reason why a patient may not respond to the same dose of medication that another patient might, or why one patient might suffer an adverse reaction or toxicity, but another patient may not. And it's not the only reason, of course, but it can be a contributing factor.
What's the best way to understand slow and fast metabolizers?
So these terms refer to the activity levels of particular enzymes within our body. Our body metabolizes medication using different enzymes. And if your body produces enzymes that metabolize medications faster, then you may not get any benefit from the prescribed dose. But alternatively, if your body metabolizes medications too slowly, it stays active for longer in your body and it can cause side effects.
So what pathways are we talking about with metabolizing medications and drugs?
Well, many of the enzymes responsible for metabolizing medications are in the liver. They are present in other cells as well. And many of them are known as cytochrome P450 enzymes. And these are complex biological pathways, and there's rarely just a single enzyme that is particularly important for any medication. There is often, however, a rate-limiting step, and this can be the difference between whether a patient achieves therapeutic levels in the bloodstream or not. And could also be the deciding factor on whether they experience life-threatening toxicity or less severe adverse reactions such as nausea. And there is one of the most important enzymes in our bodies, which is known as CYP2D6. And this particular enzyme is actually involved in metabolizing more than 25% of all medications.
I'm a slow metabolizer with what you're saying, Luke, and I just want to circle back because you mentioned the word toxicity just then. When you were talking about slow and fast metabolizers, would it be the case that a slow metabolizer a person like that could risk toxicity because the active ingredient is staying longer and then compounding with the next day's dose, the next day's dose, the next day's dose?
That's precisely right, though it does depend on the particular medication and the particular enzyme involved. And it's complicated by the fact that some drugs need to be activated. These enzymes can both clear the medication from the body, or they can be involved in the activation of a prodrug. And so the effects of a slow metabolizer can be different. In some cases, it could involve the accumulation of the medication in the body and therefore more side effects. But in others, it could be that far too little of the medication is activated and the patient doesn't really get any benefit from the dose that you're giving them.
There's two areas that we're just going to touch on that this seems to be the most used area. And one is cancer and one is psychiatry. So we'll take cancer. How is this being used in cancer medications?
Yeah, there are a few cancer medications for which this type of testing is useful. I'll give you an example. There's a few examples that I'll touch on. They include fluorouracil chemotherapies. So we're talking about 5-fluorouracil and capecitabine. That's just the same medication, really, but one is intravenous and one is an oral tablet. There's also a medication called irinotecan. There's tamoxifen, mercaptopurine, and thiaguanine. So those are a few examples. And these therapies are used to treat gastrointestinal cancers, such as colorectal cancer, some forms of leukemia, and some breast cancers. And as an example of the utility of PGX testing for fluoropyrimidines, this can inform dosing, or it can indicate whether a patient should avoid that therapy altogether. Because fluoropyrimidines are pretty toxic chemotherapies. And if you are a poor metabolizer for an enzyme called DPYD, then you're much more likely to experience severe toxicity.
So is this almost routine for cancer therapy, or cancer patients to actually have this type of testing, or is this just coming in now?
It's really only just coming in there. There are some where, for example, TPMT testing for mercaptopurine and thioguanine has been Medicare rebated and standard of care for a number of years. However, that has for several years been the only Medicare rebated pharmacogenetic test, other than one other actually. But now DPYD testing, DPYD genotyping before fluoropyrimidine therapies is emerging as a standard of care option.
Turning to psychiatry, how is it being used in this field?
Yeah, that's right. So psychiatry is another specialty where we're seeing increasing pharmacogenetic testing, particularly for antidepressants. And there are a couple of ways in which this type of testing is impacting that field. In some cases, it can reduce that trial and error associated with choosing the right medication at the right dose. So instead of trialing an antidepressant at a dose that works for most people and waiting months to assess efficacy, a PGX report may inform prescribing by indicating medications that could be avoided or suggesting starting doses for that medication. And there's a second use, a use case that potentially limits side effects such as nausea. And this is a common side effect from selective serotonin reuptake inhibitors, SSRIs. And a PGX report may help to indicate a reduced dose that might resolve these gastrointestinal symptoms without resulting in a deterioration in mental state.
Is there other fields of medicine where this is likely to have a significant impact?
Certainly, those are two of the main ones, but PGX testing is also relevant in other areas of medicine. They include pain management, cardiology, rheumatology, gastroenterology, and infectious diseases as well.
What's the future of pharmacogenetics looking like then?
I think it's definitely relevant in certain clinical scenarios, and I see those clinical scenarios increasing gradually. And as evidence accumulates from ongoing clinical trials, I think we'll see this type of testing become relevant for more medications and in more fields of medicine. However, I think, in my opinion, it should only ever be used to inform prescribing. It shouldn't be used to dictate it. And I think we've got to remain mindful of its limitations, and I think consider the broader picture when making prescribing decisions. Our response to medications is more complicated, I think, than just what's in our genes.
Is there any way to predict what drugs will be affected by genetics?
There are many medications from the same class of drugs that share chemical similarities. They're metabolized by the same enzymes and they're often associated with the same adverse reactions. And some examples include aromatic anticonvulsants such as carbamazepine, oxcarbazepine, phenytoin, lamotrigine, and there are many others. I won't list them all for fear of boring you. But it usually takes several years and many clinical trials to build convincing evidence that demonstrates an association between genetics and medication response, and then even longer to get this to be recognized as standard of care.
Do you have any advice for doctors about pharmacogenetics?
Well, I think it's fair to say I'm a healthy skeptic. I do believe that pharmacogenetics definitely plays a role and can inform prescribing, but I don't want to give the impression that PGX testing is a panacea that will help it optimize all kinds of prescribing. That's simply not the case. And PGX testing is relevant for certain medications, and it's good to be aware of which medications it is relevant for. But even for those medications, as I said, PGX testing can inform prescribing but rarely dictates it. And this type of testing simply provides doctors with more information to make the best prescribing choices. Pharmacogenetics is just one of the factors to consider in deciding the right drug and the right dose. So my advice would be to be aware of the medications for which PGX testing is relevant and consider testing before prescribing. And for those medications that have life-threatening toxicity, this is obviously more important.
We are continuing our conversation now with Professor Luke Hessen, and this time I'd like to shift gears because the RCPA recently issued guidelines about pharmacogenomics. What were the key recommendations for doctors, Luke?
The purpose of the RCPA's pharmacogenetic indications was to provide a resource that informed prescribers about when PGX testing was recommended. And before I get into what the recommendations are, I think it's worth telling you a bit about how we developed them and the process for that. So firstly, the RCPA pharmacogenomic indications were developed by a very large multidisciplinary team of leaders in this space from across Australia and New Zealand. And it involved clinical pharmacologists, genetic pathologists, clinical scientists, general practitioners. It involved representatives from the RCPA, several universities, including Monash, Adelaide, Sydney, UNSW, and the University of Auckland. We had board members of the Australian Medicines Handbook, members of the Centre for Medicine Use and Safety, and also representatives from both private and public testing laboratories that offer PGX testing. So a very large, comprehensive, and highly qualified team of experts that was purposefully chosen for their diversity and expertise, but also their different affiliations across Australia and New Zealand to really try and capture that prescribing environment across the country and across New Zealand as well. So what we did is we firstly identified gene-drug pairs that have pharmacogenomic evidence and that were also listed within the Australian Register of Therapeutic Goods, the ARTG. And we had to assess what the strength of evidence was in each of those gene-drug pairs. And for several medications, actually, we found insufficient evidence to include them in the RCPA pharmacogenomic indications. The evidence was just too weak, and we'd set our bar deliberately high. So it was a resource with high clinical utility. Then, for those where there was evidence, we needed to place them in one of three categories. They were recommended, consider, or no consensus. So I'll just explain what each of these categories mean. Recommended basically means that most places, most professional organizations and international regulatory agencies recommend testing. This is the highest level of evidence. And testing is recommended ideally before exposure to the medication. And evidence shows that adverse effects can be severe or life-threatening, or that therapeutic failure could cause patient harm. So that's the first and highest level category, so recommended. Then there's consider, and this is the category where pharmacogenetic testing essentially can be considered because the evidence suggests that the risk of adverse effects or therapeutic failure is significant, but it's not life-threatening. International regulatory agencies and key professional organizations generally recommend testing, but there isn't a consensus across all of them. And then the category of no consensus was for those where pharmacogenomic testing is available, but there's no consensus from those international regulatory agencies on the clinical utility of PGX testing. And there was also no consensus within our expert working group. So those are the three categories. And of course, the recommended is the most important.
I would just like to make a footnote here. I think the Australian Parliament should take note of how you had such a broad, diverse range of professionals who came up with outcomes. That's all.
There's 12 medications that are recommended. Now, I hesitate to read out all 12 because this will change in time.
You make me pronounce them.
This is, just an example of some. So allopurinol, carbamazepine, clopidogrel, phenytoin, voriconazole. Now, that's some of the. Now, those are actually some widely used drugs as well. These are recommended. Is this going to extend in time? Is this to happen? Does these go in the next few years? I mean, how is this going to happen that drugs go between different recommended and considered categories?
I don't see a huge change in that list in the near future, but they will be added to gradually. I think we'll see that recommended category increase by, 1, 2, or 3 extra medications over the next couple of years. We are working on adding another, and that is irinotecan and UGT1A1 testing for that. It may reach recommended, or it may end up in the category below the consider. But generally speaking, the process for identifying gene-drug pairs that have pharmacogenetic evidence for testing, you need multiple clinical trials, and it takes years to get to that point. So I don't see it changing hugely. But these are the 12 at the moment that have a lot of evidence for them.
What are some of the adverse events that we're talking about with not testing patients?
There's quite a few, and they range in severity. I could describe a couple of them. They include maculopapular exanthema, skin rash basically, but it's one of the more severe examples of a skin rash. We have something called DRESS, or drug reaction with eosinophilia and systemic symptoms, and this is a severe allergic response triggered by the immune system. It involves, it has systemic involvement. It can affect the liver, the kidneys, the heart, and other organs. It can involve swollen lymph nodes. Then there's a couple of quite severe conditions called Stevens-Johnson syndrome and toxic epidermal necrolysis, which does sound nasty, and it is, because this is a very serious condition. They have high fatality rates of around 30% for SJS and 50% for toxic epidermal necrolysis. And they're actually the same condition, but it is how much of the skin surface area is involved. So it's 10% for Stevens-Johnson syndrome, but 30% or more for toxic epidermal necrolysis. And this is particularly nasty. It's associated with blistering, peeling of the skin, inflammation of the mouth, eyes, and the genitalia, fever, fatigue, organ inflammation, and even organ failure, and finally sepsis if it continues. And so, that's very serious. And then with clopidogrel, as an example, this is a platelet inhibitor medication that's used to treat heart disease and stroke. And this one's a bit different because if you give it to patients that are poor metabolizers for CYP2C19, you're giving the right dose, but they're not activating the drug in the same manner. And actually, because they're not activating the drug at the same rate, they're actually at higher risk of cardiovascular events such as myocardial infarction, ischemic stroke, and coronary stent thrombosis. So you're treating a condition with a medication that's simply having no effect, and they develop these symptoms even though they're on the medication. So that is not it's not an adverse side effect per se. It is a therapeutic failure problem.
Going through the reading of all this, you come across some acronyms that I'm not familiar with. Can you tell us what DPYD genotyping is?
Yeah, DPYD genotyping basically identifies any variants that may be present in the DPYD gene, and those variants usually result in a loss of function of the enzyme that is encoded for by the DPYD gene, known as DPD. So there are this group of medications or chemotherapies that are used to treat a variety of cancers called fluoropyrimidines. They're used to treat colon cancer, for example. And these fluoropyrimidines are metabolized and cleared from the body by DPYD, or the enzyme that it encodes. And individuals who are poor metabolizers are highly likely to experience very severe toxicity if they're treated with the same dose of fluoropyrimidines. And the symptoms of that toxicity can include severe diarrhea, inflammation of the mouth and throat, skin reactions including hand-foot syndrome, myelosuppression, so neutropenia and reduction in the red blood cell or reduced blood cell production, but also cardiotoxicity. And about 10 to 40% of patients experience these severe side effects. Now, not all of these are due to DPYD deficiency, because they're quite toxic chemotherapies even without that. But if you do have DPYD deficiency, then toxicity is much more likely, and it's more likely to be severe, and you're more likely to be hospitalized because of it. So before treatment, it's recommended that patients undergo DPYD genotyping to identify those that have deficiency and who should receive a reduced dose of fluoropyrimidines or actually avoid fluoropyrimidines altogether.
Where is Australia sitting with all this PGX testing versus places like the United States and Europe?
Well, PGX testing is happening much more frequently in the United States and in many European countries. For example, they've been recommending genotyping for DPYD for many years, whereas this has really only just attracted Medicare rebate in Australia. So that is an announcement this year that from the 1st of November, there will be Medicare rebate available for DPYD testing. However, I think Australia and New Zealand are catching up, and we now have several providers of PGX testing. We now have national indications for PGX testing, as we've just touched on, and there are several pharmacogenomics tests that are now Medicare rebated, although there could be more. They include TPMT for mercaptopurine and thioguanine, HLA testing for allopurinol and abacavir, DPYD testing now, as I just mentioned, for fluoropyrimidines, and we're actually waiting on an announcement regarding a recent MSAC application that I was part of for HLA testing for carbamazepine and oxcarbazepine. So we are gaining momentum here, and it is being recognized as a test with high clinical utility in certain clinical scenarios.
Now, we mentioned in this area that there are guidelines for doctors. Where can we find out more about these guidelines?
So these are on the RCPA website. This is freely available. It's not behind a paywall. And this indications website has been developed by a professional website designer. And the primary goal when we put this together was to make it as simple as possible to use. We wanted to make sure that it had the minimum amount of carefully chosen information. We recognize that prescribers are time poor, and we were also very deliberate in not duplicating existing resources. We wanted this to be used with the intention that it would be complementary to existing resources and that it was specific to the Australasian prescribing environment.
Now, there is some out-of-pocket expense at the moment you mentioned that where there is movement in this area, but is that likely to change in the next year or two, or is it further away?
For specific gene-drug pairs in specific clinical settings, there's already several Medicare rebates available. So that's great news, and we've had an announcement of another one this year, with hopefully another coming. However, I think for those tests with panels of genes, there is no Medicare rebate available, and I don't see that changing in the next year or two. But these tests usually cost under $200 for a panel of genes, and I think that's quite reasonable for such a comprehensive test. So I do think it's affordable for many, and that type of testing, even though it's out of pocket, has been growing significantly, especially within my lab for several years now.
Apart from me moving forward, always asking my GP upon medication to think about metabolization, I'll put that to one side. What's your final advice for doctors listening about pharmacogenetics testing?
I think I'd come back to my earlier comments about it not being a panacea and it being relevant in particular clinical scenarios and for particular medications. But for those doctors who are regularly prescribing those particular medications, I think it is very important that they're aware of that and that they consider it before prescribing. Of course, there's the proactive model of testing where it's done before prescribing. But it could be even preemptive, where you get a pharmacogenomics report that is relevant for the lifetime of that patient, and it might not be relevant right now, but it will be relevant in the future. We're often seeing the type of testing that is reactive, and that is trying to explain lack of efficacy, trying to explain toxicity or adverse reactions. And while that has utility, I think it would be better for the patient to do it proactively before prescribing. And I think this is particularly important because, there are over 400,000 emergency department presentations and over 250,000 hospital admissions because of medication-related problems. And the Australian Commission on Safety and Quality in Healthcare estimates that 2 to 3% of hospital admissions are medication-related, and they cost the government around $1.2 billion annually. So we really should, I think, be doing this proactively.
On that note, Professor Luke Hessen, thank you for joining us on This Medical Life.
Thank you for having me. It's been a pleasure.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/IN/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.